We're live on YouTube. Three minutes. Coming up on 1 minute. Zach, you'll monitor YouTube chat, if you don't mind.
Yep, no problem.
Sue will monitor Podbean. Okay, sorry, we are running a little late, had a bit of a problem. Okay, give us 20 seconds and we'll go live. Ready?
Welcome to episode 105 of the ASC podcast with John Goehle for May 18th, 2020. Recording live from our studios in Spencerport, New York. This is Susan Cronkite, Chief Researcher for the ASC podcast with John Goehle and Senior Nurse Consultant. for ambulatory healthcare strategies. The ASC podcast is sponsored by Ambulatory Healthcare Strategies, Surgical Information Systems, Encompass Healthcare Data Solutions, BHG Patient Lending, Medicus IT, and our newest sponsor, Intillair. For more information about our sponsors, visit our website at ascpodcast.com. Joining me from our studio in Spencerport is John Goehle, recognized as one of the nation's leading experts in the ambulatory surgery industry. And joining us is Lori Rodericks from Cape Cod, Massachusetts. She is the Director of Clinical Services for AHS. From Rochester, Judy D'Ambrosio, Director of Educational Services for AHS. Jenna Alvarez, Senior Nurse Consultant for AHS. And in Atlanta, Georgia, Zach Kaloritis, Financial Consultant for AHS. Sorry, Lori was all of a sudden.
We had two different angles of Lori.
And I totally threw me.
It really threw you
Get my
off.
best side. Sorry, I was changing computers. I was
Multiplying.
That was kind of funny. Lori really wanted to be on today.
Sorry.
Oh, no problem. So I'm sorry. And just as we were going live, I got an email from somebody that I had to correct. One of those urgent things.
So you were telling me earlier that we've got a lot of downloads.
I know,
right?
20,000 downloads we hit this last week. And not only that, but we our numbers are well over double what they were pre coronavirus. So we're over like about 350 to 400 downloads per episode. So we do apologize that we've been running. Well, it's been about 2 weeks since the last podcast that we've done here. We will be speeding them up again. But as you know, there's been a lot going on. And interestingly, we haven't had a lot of news to announce because everything has kind of been a holding pattern. And we have been concentrating, of course, on the virtual conferences lately, which are much more important as we get everybody geared up. So, and by the way, that was a long list of sponsors. I know. We have picked up a number of sponsors during this time frame, and we're very pleased to welcome all of them. And thank you for the support of this program. It's a much needed service, I think, and certainly a lot of things have come out as a result of this podcast over the last 3 months. How long have we been doing this? Anybody know?
Forever.
It seems that way. I did want to kind of update, remind everybody that we have done a lot of virtual conferences, and many of these are very important. And you can access information about these virtual conferences on the website at ascpodcast.com. Excuse me. So the first one was the ASC Infection Prevention Coordinator training that Lori did about 3 weeks ago. It was a 6-hour program to prepare infection preventionists for their job as an infection preventionist in an ambulatory surgery center, and also for existing infection preventionists to kind of up their skills a little bit, or just to kind of keep updated on what's going on. And there was a little bit of a concentration on the post-COVID-19 world. We know things are changing, and of course there'll be a heavy focus on this. Then we did the It's a New World Conference 2020, which was a 2-day conference with about what do we end up with? 14 and a half hours, I believe, of AEUs for CAST credentialed individuals. And it was a great conference meant to kind of replace those conferences that we've all kind of missed during this time frame. And we had a lot of fun with it, and that's available also on our website. Then we did ASC Roadmap to Recovery. Got a lot of rave reviews. That was by far our most highly attended conference, where we helped prepare everybody for starting up again elective procedures, and helping people understand that it's not just a matter of just a matter of opening the doors and letting people in. And lastly, the 2020 ASC annual mandatory education program that we developed in order to kind of take advantage of this time frame we have right now, where we're we're getting prepared to start cases, but haven't yet started them necessarily, where we might have employees on hand that are we could do the mandatory education earlier rather than doing it a little bit later on when we're going to be a lot busier. Then we have two conferences coming up. Lori's going to talk about one of them in a few minutes, infection control and in-service to meet the challenges of COVID-19. And then in June, that's going to be on Wednesday, right, Lori?
Yeah, the 20th.
And then the ASC Finance, Accounting, and Reimbursement Seminar, which is coming up in June. And again, all information about those, and that's a 2-day conference also. We're going to be doing that with Christina Benton. And so for more information, go to ascpodcast.com. Let's talk a little bit about some of the recent news. Talking about virtual conferences, the ASCA 2020 virtual conference and Expo is going to be happening live July 9th and 10th and available on demand until October 31st. For more than 2 decades, ASCA's annual conference has remained the premier can't-miss event for the ASC community, and this year's virtual conference is no different. Just like ASCA's in-person events, the ASCA 2020 Virtual Conference and Expo offers nearly 50 educational sessions, access to more than 100 exhibitors, and unique virtual networking opportunities with hundreds of your peers. For more information, go to ascassociation.org for more information. It's a little redundant there. I just recorded my 2 sessions. So the way this works, unlike our virtual conferences, which we record live, the ASCA 2020 virtual conference, all of the sessions are recorded, and then they will play them live. And then those of us that presented will be texting answers. So in other words, people will be watching it and then typing in questions, and then I have to answer in real time as the conference is going on. That's going to be interesting to see how that goes, especially for somebody like me who can't type that well, but we'll see. But it was actually fun. I enjoyed recording it, and surprisingly enough, even though there weren't, I didn't have an audience, and as everybody knows, I like to have an audience. But I think it's going to be a very good session. I still don't think it's quite as good as, when you got live questions being thrown at you and you're being interrupted, and, you're getting that instantaneous feedback as you're presenting the session. I think any of us that do this for a living know that feeling, and we'll have to see how well it goes, but definitely take an opportunity to pick up. This is really, 50 educational programs, within a 2-day time frame, and then the ability to revisit them over the next, I think it's another 3 or 4 months after that, is definitely a big advantage. So, anybody else have any comments about ASCA 2020? Lori, are you doing any presentations for 2020, or is it just Christina and me? I couldn't remember.
No,
Yeah.
not this year. No.
I know Lori's on the education committee, and by the way, you probably noticed two glaring people that are missing. Alex is on the road. He went on the road again today, first time out of the house for quite a while. I go on the road next Tuesday, and Ann Geyer is not with us today. I have no idea where Ann is, so we'll find out in a couple days, I guess. But we do miss them and their feedback, and I haven't heard from Jim either, so we have no feedback today on life safety. Sorry about that. I did want to kind of give a quick update on Hospital Without Walls program. You might remember during the issues of the 1135 waiver, the Hospital Without Walls program was one of those things that was allowed under the waiver, which would have allowed a surgery center to request to become a hospital for a limited period of time. We had one of our clients interested in it. Then we looked into the situation, told them the challenges that they would face in doing this, and they decided against it. As I understand it, in talking to the ASC Association, about 12 ambulatory surgery centers did apply and got approved for it. I do not know the status of that. I know one center in particular, there was did okay or got on board pretty quickly, but at this point, it's really not advisable to look into that, as of course we are starting to open up again. But if you do want more information about that, please reach out to me and just send an email to info@ascpodcast.com. Be glad to provide you more information. Sue, why don't you talk a little bit about something was in Becker's today, I believe.
Yep, I just I had seen in today's Becker's ASC review in a preprint study published on MedRx IV, I believe, I'm not sure if I'm pronouncing that right, done on resident physicians in New York City. 45% of the 340 residency programs reported that at least one resident with had COVID-19, and that was confirmed, and it was a much higher number that were suspected. And 99% of these physicians reported reuse or extended use of N95s, which is something we talk a lot about, is the N95s. And 60% felt that the PPE was suboptimal. I know that's no surprise, but just some interesting numbers. And they had mentioned the 3 specialties that were at highest risk of contracting COVID. And I think the first 2 will not surprise anybody, anesthesiologists and emergency medicine. But the third, ophthalmology physicians. I think that might surprise some people. It's, for one thing, because obviously you're very close to the, to the mouth of the person when you're looking at their eyes. But also from the American Academy of Ophthalmology, quote, a recent study from China suggests that up to 1/3 of people hospitalized with coronavirus experience eye problems such as viral pink eye or conjunctivitis. It's important to note that virus can be spread by touching fluid from an infected person's eyes or from objects that carry the fluid. And of course, it can go the other way if, somebody's coughing and you're near and you don't have your eyes covered, which of course people don't walk around with their eyes covered. You can get that virus in your eye, and there is a slight chance of, having some issues that way. And we're going to attach a checklist for reopening from the American Academy of Ophthalmology that they suggest for their ophthalmology centers. So.
And to that point, I'll also relink our checklist for reopening in our podcast notes for this week. We have created a lot of resources for you as you start to reopen. And I guess I just need to emphasize this again, and Lori, feel free to jump in. I know your physicians are putting you under a lot of pressure to open up, I should probably better to say to open up for elective surgery. A lot of you are still open, doing non-elective stuff. But we have to be very careful about this. I have spent, seems like all of last week and so far all of today dealing with issues of places that are trying to open up or don't, that the doctors just don't realize that they can't open up, quickly. And we've provided a lot of resources on our website. We have done a virtual conference, ASC Roadmap to Recovery. Lori's going to be doing the session on Wednesday, which we'll talk about in a second. And I really, really encourage you to, avail yourself of this resource and make sure that you open up very carefully as we move forward. Anything else on that, Sue?
No.
So moving on, let's just talk about 2 states in particular right now, especially New York, because we know we have a lot of listeners from New York, and we know that New York is really in the headlines and could very well become a model for other states. Parts of the state are reopening. We were told that parts of the state would be allowed to reopen for elective procedures. However, and this is what I've been dealing with for the last week and a half, is you might have been told that you can reopen for elective surgery, but we have not been provided the guidance as to what the terms of reopening would be. So at this point, we know that you're going to have to meet certain conditions. For example, there are most likely going to be testing requirements. There's most likely going to be an attestation that can be done.
Yes.
Facelift, and she's back there getting this done.
We're getting background noise.
Is that you get to review the full results later in the show.
Hang on.
Can we mute it?
Can't see who it is. Okay, sorry about that. Oh my goodness. Guess who's joining us from Virginia? Christina Benton, are you there?
I don't know if you can hear me.
I can hear you.
Hello. That was the background noise.
That was the background noise. Welcome, Christina. That's great. Hang on, Naira. I'll introduce you in a second. But anybody else here that I didn't know? Okay. Nope. Welcome to live podcasting. So, if you are in New York and you are in one of those counties that is eligible for reopening, please recognize you really should not be opening for elective procedures until we get that guidance, because we know that there will most likely be an attestation If the attestation looks at all like the hospital attestation, it's going to be kind of scary. There's a requirement for a certain amount of PPE, and that means that you would have to have this PPE available without accessing the, the emergency stockpile. So please stay tuned for that. We are closely monitoring. We're literally monitoring our cell phones right now for when the governor's announcement will come out of what those things would be. Laura, you had an update because you were talking in Massachusetts today about their reopening plans. You want to give us an update on what's happening out there?
Yeah, the governor is doing Massachusetts in 4 phases, I think like the rest of the world. And phase 1 is kind of like it is right now, the urgent, very, very emergent. And that, I believe, I don't have the information in front of me because unfortunately I was driving, but the gist of Massachusetts is that every ASC has to sign an attestation. So similar to New York, where the hospitals had to sign an attestation before they resumed elective procedures, in Massachusetts, the ASCs also have to sign an attestation. And the big push with that is to make sure that you are claiming that you are pretty much only doing emergent or cases that if left unattended would cause further harm to the patient. I don't have the exact words in front of me because I was writing as I was driving, but it's it is in all the paperwork that got sent out to the Massachusetts ASCs.
There goes my workers' compensation insurance.
I actually was in this passenger side, I promise. So the whole thing is the fact that they are, you as the center are taking that responsibility, making sure that you're saying that we're only doing those that are going to save patients from harm. The higher risk cases and significant worsening of the condition or a condition. Those are the 2 things. And that pretty much, they might be able to reopen a little more starting next Monday, the 25th. But again, it's just for those procedures. So if they're not already doing cases today, it's suggested that they don't start until next Monday, but they download the attestation. Although if you were a member of the Mass ASC Association, you're going to get it and fill it out and send it back to the Department of Health. Now, the other thing that was kind of interesting was the president of the association on the call had informed everybody that at one point in the last couple weeks, DPH came into his facility and all of the medical facilities that happen to be in his building. I don't think there's a lot. I've been to his facility before, but he's on the 2nd floor of a big, a bigger type complex. But I think they have like physical therapy and stuff like that. And they were walking through to see, oh, what are you doing? How are you set up? How have you done things? So they're out there. He wasn't sure why they came to him. Part of me would say, well, because you're the president of the world. But, who knows? So the big thing is that they're setting guidelines as well for ASC, similar to New York. That you have to have things posted, that you have to do certain training. And that's where Wednesday comes into play. A lot of the stuff that we're going to be talking on Wednesday will fit into the requirements that at least that the state's looking for, for your staff and and providers that they're trained on for infection control purposes, social distancing they want people trained on. Okay. So that sort of thing. But they did not spell out, they did say in one of the things, colonoscopies. I know there's a lot of GI centers out there that, family history or pre-existing cancers or active bleeding, those are considered, appropriate. Routine 10-year screenings, nope. No,
Okay.
not at this time. They really didn't say much about cataracts, but, and especially not on high risk, if it's a high risk cataract, you have to document really good why you're doing it. But, if I have the cataract, to me, it's high risk. But if I can't, as a provider, justify it appropriately, so they're going to be looking at that stuff. So
And we
it's,
know it's going to be the same thing in New York too. It's going to be
yeah,
very,
yeah. I mean, he even, Greg from the Mass, even spoke to them one-on-one, and said, but what about the cataract patient that if we don't take care of it and they fall and they break their hip or they get a brain bleed, but they weren't really falling for that. Although, that is quite a possibility. If you're 90 years old and you have a cataract, so now you can't see, it could lead to something much more serious. But total joints, if they're elective, nope.
Yeah.
It's tonsils and adenoids, no.
yeah.
Ear tubes, nope. It's like, really? So they kind of spell things out a bit.
So it
But
looks like actually in Massachusetts, you're less open than New York is.
yeah, I'd say
really-
the majority of centers are not opened.
Right.
If you're multi-specialty, kind of like orthopedic based,
Yeah.
you're more than likely open, but very limited. But I think a lot of the GI centers, a lot of the eye centers are not open at this time. Plastics, no. Pain, no.
I did want to introduce a dear friend of ours, Christina Benton, who we asked to join us, and we weren't able to touch base with her before we went live here. Christina, welcome.
Hello. Thank you for inviting me. Sorry for interrupting.
Oh, no problem. So Christina is the president of CCM. Oh, let me see if I can do this. Coding Compliance Management.
That sounds good.
Oh, there we go. And our dear friend Lori and I and Christina go way back. We're old time drinking buddies. Are we supposed to say that on live podcast?
Virtually.
Osmosis.
Yeah. And so this is actually a bit of an experiment too, because Christina is joining us from the top of a mountain in
Franklin, North Carolina.
North Carolina. Thank you.
It's almost Virginia, John.
The last time we had her on the podcast, she kind of faded in and out, but it sounds like you got a pretty solid connection today, right?
Knock on wood, almost too much.
Okay, I know. I'm gonna have to turn your volume down just a little bit there. So Christina, actually, Christina, welcome. Tell me what's going on right now, because coding, of course, never stops. We talked a little bit the last time about the importance of not letting your people go who are doing your coding and billing. But tell me what's been happening in your world and how your people are gearing up.
Well, it's interesting what Lori mentioned about the pain management, because we're seeing a lot of centers that either they're really ramping up on the pain management, people that can't wait and they're needing their ESIs, versus some of the centers that never really unofficially closed and they were always trying to get a day in for pain management. But as far as ramping up, we're almost at 100% back to normal, except for one facility. From our perspective, the coders are slammed. It seems like everybody's trying to get into this window of opportunity to perform these surgeries, but the facilities are performing their due diligence, trying to get these patients tested
Good.
ahead of time. But from the coding speak, we're just trying to ramp right back up and fall back into place with doing our daily responsibilities to the centers.
So let's talk a little bit about an upcoming conference that you and I are doing in June 11th and 12th. ASC Podcast with John Goehle and CCM, or Coding Compliance Management, are jointly producing, hang on, I have it on my screen, the ASC Finance, Accounting, and Reimbursement Center.
Correct. You'll be doing the coding and I'll be doing the finance and accounting.
Oh, no.
A new switch to the ASC industry.
Oh, man. I have a hard time avoiding nice about it.
Watch out, world. Watch out.
Will never be the same.
So we do have an update on this. So let me just kind of read you the spiel here. Learn and earn while you travel without the travel and join ASC industry experts John Goehle, Christina Benton, and Ann Geyer for this intensive 2-day virtual conference with finance, accounting, and revenue cycle aspects explained. ASC administrators, nurse managers, and business office managers face unique challenges in managing the financial aspects of an ASC and understanding the crucial role coding experts play. Our experts will discuss various aspects of finance, accounting, and reimbursement in the ASC setting. It is ideal for anyone interested in understanding basic finance principles as well as those that know finance but want to learn how it differs in an ASC setting. Our experts will also review the ASC reimbursement model to include an overview of the fraud and abuse prevention, coding, documentation, outsourcing, and compliance audits in an ASC setting, as well as the impact coding accuracy has on your organization's financial health. I think there should have been a period in there somewhere. The good news is this program is approved for 13 hours of AEUs by Basque Provider 2618. This is for CAS certified administrators, and AAPC CEUs are available for up to 14 CEUs for coding, auditing, compliance, billing, and/or certified physician practice manager professionals. I'm sorry, I don't understand the last words there. Pending need for Core A, Core B, or our specialty CEU requirements.
Right. The AAPC, those that need CEUs, they need to check and see what CEUs they need to fulfill.
I got it. Okay. So for more information and to register, please go to ascpodcast.com or either CCM's website, which is CCM. What is your website address?
My outside address?
Yeah, your the address for your company.
It's Franklin, North Carolina.
No.
129.
Sorry.
CCM Pro. 1 + 1 is 2. The dog ran down the street.
Oh, we are going to have so much fun on June 11th and 12th.
My ex-husband lives in Texas.
Pay to watch this. So I believe what she means is ccmpro.com is the website for that. And of course, ascpodcast.com for our company. Oh, we are going to have a lot of fun on that day. We even offered, by the way, team, we actually offered to bring Christina. We weren't sure we were going to be able to get a fast enough internet connection for her. So we offered to bring her up to Rochester so that all our dogs could meet each other, which would be very interesting, I think.
We'll never be the same.
So thank you. I mean, I'm looking forward to it. I think one of the things that is important here is that really, there's going to be a lot of financial impact of the coronavirus on our industry. And, I think as we're developing our programs, obviously we're trying to deal with helping people to understand financially what happens in ambulatory surgery center, especially for nurse managers. I think a lot of nurse managers, come to it with very little expertise in ambulatory surgery or in finance. And I think that's definitely something that we're going to be very helpful in explaining. But also, trying to discuss some of the financial some of the things that specifically we're going to have to deal with over the next 6 to 12 months. I think it'll even be longer as a result of this. So definitely, I think this conference is coming in at a very timely basis. The other thing that'll be helpful is that the CAST review course, unfortunately, had to be canceled because we couldn't pull that off virtually. And one of the sections of the CAST review class included education on finance and accounting. So this will hopefully help all of the people that are looking to go and get their CAST certification to at least pick up that portion of it. Any other thoughts there, Christina?
I think it'll be a good opportunity for those that are new and those that are the experts to be able to just even pulling in your CEUs and AEUs without having to do the trouble and worry about the environment that we're in now. But these managers need to know enough about the reimbursement piece and really be able to do a dig deep within our conference so that they can question and they can do their own self audits going forward.
Well said.
Don't miss it.
Please don't. Again, ascpodcast.com, ccmpro.com. Sign up for it. And I noticed that we've We're getting people signing up. I got emails coming in left and right here. I don't know what the heck's going on. It's distracting, so I apologize. Let's talk a little bit about in-services for a minute that you should be doing for your staff during this difficult time. I had an interesting conversation this morning with a former client of ours. They're currently clients. They're one of those clients that hires us periodically, when they need help, but they're not a retainer-based client. And I was mentioning the importance of updating your staff on a regular basis, preparing them for starting up elective surgery, and that you really should be having ASC in-services specific to COVID-19. And this individual said, "Oh yeah, we've been doing it all along." And I'm thinking to myself, "Oh boy, without bringing experts in that really understand this, I'm not sure that that's going to be totally appropriate." So be very careful to make sure that you are keeping up with this. As Lori indicated is happening in Massachusetts, I'm sure it's going to happen in New York too, where we're going to see surveyors kind of showing up unannounced just to double check to make sure that we are taking the precautions that we need to be taking. And of course, HHC, Joint Commission, Quad ASF, all of those other surveyors are going to be very, very active looking into every nick and cranny in your organization to make sure that you're following up on all the infection control requirements. Lori, why don't you tell us a little bit about, you've got a session next week. So, obviously we can offer it for you. We're going to record it live on Wednesday, but if you decide not to use our training, why don't you kind of give an update on the type of training that they should be, what we're going to offer, and also recognize that this is the type of training that you absolutely need to be giving to your staff, whether we offer it or you get it elsewhere.
Well, thanks, John. I have in front of me the governor's thing from Massachusetts, and I'm sure Jenna has memorized the governor of New York. But the things that they're going to be looking for and what they're expecting for staff, especially with training, is they want all your staff trained, and staff also includes providers, regarding social distancing, regarding your
All right,
height.
let's just back up 1 second. That phrase that you just kind of threw away is extremely important, in that we need to remember that when we're talking training staff, it's important to train your providers, that is your credentialed individuals, as your employees also. I can't stress that enough. If anything, perhaps even more so, because because they're a lot closer to the patient than we are.
Mhm. Well, and the other thing too is your front desk, your front desk staff or your reception people are also going to be training whoever's coming into the reception area, that if they say they come in and they sign, their sign in or their forms, they're going to train them to do hand hygiene. They're going to be encouraging them. Oh, don't forget to use the the alcohol wipe or whatever after they put the pen down. So it's there's going to be a lot of training on that. But they're what the states want, what the DPHs want, is that everyone understands the hygiene protocols that you have in place. So that's going to be your hand washing. We're going to talk about your frequently touched surfaces, because they're going to be looking for that, and see if you have something in place. How often are you cleaning areas, restrooms, doorknobs, even your nursing station phones, the keyboards? How many people are on the keyboards? Are they doing some proper hygiene after they've used the keyboards? Just things like that in general that we don't ever think about. We're going to talk a bit about your processing department and things that they have to be aware of, and that you have to wear your PPE. It's not because you don't feel like it, and what the PPE is required for the job that they happen to be doing. And when they're doing their cleaning in their departments, how do they go about it? Starting from top to bottom, clean to dirty, stuff like that. We're also going to talk about the clinical areas, pre-op, PACU, your procedure rooms, your ORs, and also discussing ways to eliminate clutter, because if it's out, it has to be cleaned. So, it's something that we don't always think about. We're used to maybe having our IV setups at the bay. Well, that's really not a good idea anymore, is it? Because we'd have to clean everything in that container or whatever if it's not a closed environment between patients. So it's a lot to consider. So we're going to be talking about that. And then again, the big push with the PPE and, you know, the proper way of putting it on and putting it off. When do you wear it? When do you not wear it? You know, double gloving versus single gloving, masks. I don't even like masks anymore. I hate them. You know, but it's
Yeah, we're
just
going to talk
all of
about
that
that in a
stuff.
few minutes.
Yeah,
Jen is
I was
already.
hoping that would be my please don't talk about masks moment. But it's just things like that. And also you're going to want to set up something with your environmental cleaning people, whether they're employed or if they are someone that you have hired in, that they have a checklist or that they are showing evidence that they've been trained on your products, how you want things done, and that they are doing it. So usually the best way is a checklist, but you know, just stuff like that. And it's going to be generic because everybody's center is different. So we're going to try to hit all the high areas so that, you know, it can be used internally. And if you want to get more, you know, deeper down, you can, but at least you have that documentation that if DPH comes in, yes, here's our list, here's the training that we provided. Because if you just say we did it, you want to make sure that it's documented that you did it and that your staff have signed off on it. So this is an easy way than you coming up, you meaning you, the center leadership or the infection control person or whomever, coming up with these particular training sessions. Because, you know, if it's written up in a proper way, then they're going to believe that it was done appropriately. And you're more apt to do it appropriately if it's presented in a concise method instead of off the top of our heads, which I like to live on myself. But, you know, but that's for the infection control and your social distancing and traffic flow and all that good stuff. And yeah, the doctors definitely, you know, or if you do have a regular sales rep come in, or if you do have a regular PA or.
That's a very good point, is that we need to have some very good policies in place as to how we treat people that are coming in that had not gone through that training. It's not reasonable to assume we can train them, but if they're coming in, there's going to have to be some type of something that you provide to them or a conversation you have with them before they go into the operating room. By the way, it's not a really good idea for them to go into the operating room anyway.
No, not these days. No, if you can limit them to not come unless it's extremely important and can be justified, I wouldn't invite anybody in at this time until, you know, we're all back to, you know, coughing on each other. Right. But I think that's going to be a far away. You know.
Jenna, do you have any other observations? You've been working on the in-service stuff too. Well, at least keeping your clients up to date on that.
Sorry, dealing with the client issue.
I know. I've been watching because Jen and I are texting back and forth as this is going on. So go on.
Definitely for in-services, I know, you know, a lot of my centers had, well, I had a big mix, but the couple of my centers that have remained open completely have been doing little in-services all along as things changed. But then I also have a lot of my centers that had closed down completely. So their employees are back probably with whatever knowledge we gave them, you know, in the beginning of March, which a lot of things have changed in 2 months. So definitely all of those people need education on, like Lori said, all the infection control things, especially things have changed. As we start, most likely our centers will be doing some sort of testing. Once there's a CLIA-waive test that, you know, we can actually get in our centers, they'll have to get trained on that. If we do CLIA-waive testing in the centers, we'll have to get trained on that and do competencies on that like any other CLIA-waive test. Or if they're going to be collecting the specimens and sending it out to the labs. I know some of my centers, the ones that are open currently, they're collecting the specimens at the office and sending them out, but I know other centers are working on putting together a program to test at the center or in tents outside of the center preoperatively. So again, those tests the staff will have to be trained on. how to collect those specimens and what PPE to wear. And then everyone's going to need to be, once your center determines how they're going to supply PPE to all their staff, you know, it's going to be different for OR and pre-op and PACU and reception area and business office. They're going to all need to get training on how to wear that stuff. I mean, your business office probably has never had to wear masks before.
Right.
So knowing how to properly wear a mask there. Other things that have changed, you know, any other things that have changed at your center in the past 2 months, you know, your social distancing, like Lori talked about. Don't know if I'm forgetting anything, but.
Well, and we're going to talk in a few seconds about the challenges that we've seen as places are starting to reopen. Let's talk, I hate to do this, but let's talk about the N95 masks for a second. We get more questions about N95 masks. Let's also start, let's kind of get one thing out of the way pretty quickly. There's been a lot of conversation about the KN95 masks. I think everybody knows by now the KN95 masks are not FDA approved. They're really not appropriate. I mean, I guess they could be used as, I just don't know why you would do this, as a mask for, like you would just in public to cover your mouth and nose, you know, so that you don't spread things, but they really can't be relied upon as a non-FDA approved product.
Yeah, don't rely on them as a respirator.
Correct. That's what, thank you. That's a good way
You're
to say it.
welcome.
Yeah. So let's remind everybody of, if you do decide now, okay, let's dispel one thing. There is no firm guidance from any state, at least to our knowledge right now. I guess there is no consistent knowledge, certainly at a federal level, and at a state level, it's very individual to the state as to whether to be using N95 masks in your organization. We do expect to see some guidance in New York to this effect, but at this point, we don't have it. But if you do decide to use them, you have to fit test this. And I know places are saying, well, perhaps we'll get off because this is an emergency and it's better to use an unfit tested mask than none at all. The problem with that logic is that OSHA requires you, if you're going to use an N95 mask, to have it fit tested. If you don't do that, you're in violation of OSHA requirements. And as we all know, OSHA levies some very significant fines on organizations that don't follow the OSHA.
And there's also a medical evaluation that I think a lot of people forget about.
So Jen, why don't you kind of quickly run through those requirements, or Lori, whoever.
Jen, take it away, baby cakes.
So you have to do a medical evaluation on all of the staff. That can either be done at your center by a physician or professionally licensed healthcare provider. The OSHA has a specific guidance of it. Many people have asked whether a nurse can do this, and many people have gotten wishy-washy answers from OSHA. It sounds like it's very dependent on your state and what your scope of practice is, but you can delegate parts of it to a nurse and then have the doctor be the one. So the nurse can be like the one to give the test, give the form out, collect it, and kind of do a preliminary review so that she can kind of point out, like, I know what my one center is doing is having the nurse manager kind of facilitate everything, and then having, you know, so especially because if everything is no on that questionnaire, you're pretty much good to go. So she can kind of like split up the ones that everyone's going to be okay to be to wear the N95 versus the ones who might need some further evaluation. And then the doctor is probably the one who should sign off on it. Now you can also outsource this. There's a lot of companies out there that will do, actually there's one you can even do online. I think 3M even has, you know, if you're using the 3M masks, they even have availability to do it online. I think it's kind of expensive. Or in any of the outsourced like occupational health facilities, or urgent cares a lot of times do outsourced occupational health. You can have those do your medical evaluations if you're not comfortable doing them in-house.
Jen?
Oh, sorry.
Yeah, we have a question.
Sorry, I have a question. I also wanted to know if you would comment on, I know I've had a couple questions from people wondering if, I guess there's some wording in OSHA about an employer not being able to see medical records. So I've had a couple people that have thought, well, if the doctor owns the center or is in the, on the board, can they see it? But it's really.
I can't really speak exactly to OSHA, but my thoughts are if you're already maintaining, and I think Lori has the same opinion, if you're already maintaining a confidential medical health file on an employee, I don't really see the difference between this medical evaluation and, in New York State, we have to do H&Ps on all of our new staff and annual health assessments. I don't see the difference between that and this.
Yeah,
I agree. And as a matter of fact, that assessment looks somewhat similar to the New York State assessment. A little more intense, but still very similar. And I guess that's the point I need to make here is that, again, you have to take all of these steps, even if you just have an N95 mask in your in-house. So it's not even so much a matter of using it or not. By the way, if anybody's watching, Sue is swatting away. We've got this fruit flies. I don't know where they suddenly appeared. They're going all across my screen too. So we're not swatting at everybody.
Dancing or anything.
And then the last thing you might want to, well, actually we have another question before we get to the last.
Yep. What about anesthesia that is contracted to work in your facility? Does their group provide the fit testing or does the ASC provide the fit testing?
I'm pretty sure that anything that you provide in your center, you're responsible for. Just like you have to provide them with the anesthesia machine, you have to provide them with the anesthesia drugs. You'd have to and the PPE and everything. You would be doing this as well. If they are fit tested elsewhere, and they are using the same exact mask that you have at your center, then you can use that form, as long as it's within the year, but it has to be an identical mask. But
they have to wear the same it has to be the same manufacturer, same model, same size, same everything. If your center purchased the exact same mask as what they are fit tested for at another facility, that's acceptable.
I'll tell you something, I'm a little bit uncomfortable with that because you're taking responsibility for somebody else who did that fit testing. I guess a flip side of this, what happens if they take our fit testing and use it at another organization? I'm hoping nobody's going to come back at us if something went wrong for that fit testing. You see where I'm coming from?
yeah, but OSHA does allow.
Yeah, OSHA allows it.
Okay.
Fortunately, unfortunately, whatever you want to do.
Okay.
Well,
So again,
don't give them the paperwork if you're doing the fit testing. Just say, nope, sorry, it's mine.
understood.
Well,
Okay,
you
so
have
again, the thing is it's got to be the same model, same brand, same size.
Identical.
Identical. Okay. Hopefully that answers that question. And then this was the other big thing that came out of it is the respiratory program. Do you want to?
Oh wait, so we haven't finished though the
I'm sorry.
fit testing requirement. So we talked about medical evaluation, fit testing. And again, so they did waive the annual requirement. So if your center was already doing fit testing on N95s previously, they did waive the requirement for annual fit testing. There was one thing that kind of gave you a little bit of a out if there's absolutely no way that you could get fit testing. But again, Lori and I kind of had the opinion you better document that you tried really, really hard to get that fit testing, that you searched every site, they were all back ordered until July, that you've called every urgent care facility that does outsource fit testing and couldn't get your employees in there, because you're really leaving yourself at risk if you don't have that documentation of the testing.
Yep.
Agreed, Lori.
And then, sorry, keep going, sweetie. You're doing great.
So, and then I have gotten the question a couple of times, who can do the fit testing? So there's no special certification or anything you need to do the fit testing. You can buy the kit through, I know one of my centers recently bought one and she got it through her normal vendor. And It came with a video on, to train her how to do it. It came with clear instructions. So she was able to do all of her employees, I think this last week. So you can do it yourself. You can outsource it again. So I know, again, the urgent cares that do the occupational health services often offer that. Some centers have been able to have their hospital help them with it. Some centers have had the local county health department help with it. So, call around and ask. The other thing that I found, at least in the New York City area, was that there was like a mobile unit that you could bring out, or mobile service to do fit testing. And then a lot of the providers that did either CPR or ACLS training, they also had N95 fit testing services. So, just kind of, simple Google search can get you very far in your area. Find out what's available. Anything else to add on that, Lori?
No, not on the fit testing.
Okay.
Respiratory program.
So in regards to the respiratory program,
And again, some perspective, we're talking about if you are going to be using an N95 mask, these are the requirements. So I'm sorry.
that's okay. So in OSHA, in OSHA land, I can give you the numbers, the 1910.134 C1. What it says is in any workplace, and that's the key, any workplace where respirators are necessary to protect the health of the employee, or whenever respirators are required by the employer shall establish and implement a written respiratory protection program with worksite specific procedures. So yes, you bring a respirator into your home and you expect someone to use it, then you have to have a program. There's been a lot of
Alex of that.
Oh yeah, good point. Good thing he's on the road.
He's got respirator. What we mean is that we have employees that actually have N95s at home, and I guess technically there's a requirement.
I don't think you should have told anybody that, because that would put him in harm. But
we do have a respiratory program.
Yeah. So there's been a lot of chatter on
that's voluntary use of the N95. There you go.
Yeah.
Get you out of everything.
Yeah. So the whole thing, back and forth, and one state, the OSHA person said, well, it could be voluntary, or so you don't really have to. You know what? No. That guideline says you have to. So either the OSHA person didn't understand the question, or just gave a really easy answer, because then another OSHA person can come in and say, where is it? And here's the guideline that says you have to have it. So, you'd be setting yourself up saying, oh, well, when I called 4 weeks ago, I don't remember who I talked to. They told me this. If you don't have it in writing that they say, oh no, we're going to waive it for you, then go ahead. And OSHA is usually, I think, federal. I don't think it's state. They have different
There's
sites.
both. Right. There is both.
So, if the federal guideline's telling you have to do it, and the state guy says you don't, the federal's going to win, just because it's a higher hierarchy of rules.
Higher standard.
Yeah.
And that is a good point to make, is that if you're you do need to check your own state to make sure that they don't have any additional standards in addition to the federal standards. And if those standards are stricter than the federal standard, then they will be what falls into play here.
Yeah.
So these are pretty serious requirements if you are going to be using an N95 mask. And I know that a lot of places are not necessarily following these guidelines. Please understand the risk that you're taking. OSHA doesn't fool around. If they find out about it, if somebody turns you into OSHA, which is another, like a whistleblower possibility, you could be finding OSHA inspectors showing up and fining you 5 figures easily, for this. So be very careful.
And we do have a question. So how can we say we will use the same masks, brands, etc., when we are getting what we can from wherever we can? And I think
what I'm saying is you probably are going to have to fit test it yourself.
Yeah, fit test for the particular
So,
you have. If you have more than one, you may have to
Right.
do.
yeah,
you know,
if
just
the
follow-
one that you bought or that you're able to get happens to be the same one that they're already fit tested for, then you don't have to worry about it. The other thing is, if you are only getting like, a certain supply of one type of mask and then another supply of another type of mask, each
Mhm.
time you switch to a different brand / type of N95, you're gonna have to separately fit test
Right.
them for those different types of masks you're using.
Which really probably wouldn't be out once you've got the fit testing equipment and you're, and you've run through
Well,
it.
the only problem is going to be if you're outsourcing it, you
Mhm.
probably want to
Oh,
have
yes.
know in advance the other masks that you're gonna. I mean, if you already have a couple different types
Oh, that's
of
a good
masks.
point. Yeah, have it all done.
Yeah.
Yep.
Okay. Have we killed the subject of N95s?
Not for
oh, no.
long,
I
I
hope
don't think.
so.
No, I guess another point we do need to make is that you need to remember that if you're doing a procedure, I know this is kind of obvious, but I guess it needs to be said. If you're using a mask in a procedure, during a surgical procedure or any type of procedure, due to cross contamination requirements, in other words, that
Don't
the
do
need
it.
I'm tongue tied today.
I
The
know.
need to assure that you
No,
don't cross contaminate anybody else. You have to use a different mask for every single procedure. So now, which means that it's really not reasonable for you to use an N95 as a procedural mask unless you cover it with a mask that you can throw out in between procedures, between each procedure.
Unless you're, I mean,
Yeah, if you're
the best
protecting it,
practice would be to use one mask per procedure and then throw it out because it's a single-use device.
Right.
However, under the crisis capacity and what's the other term, Lori? Contingent or
yeah, contingent and
contingency. The CDC has put out some guidelines for both contingency and crisis
yeah,
capacity strategies. I think I got the term right there. For use of the mask. So that's what a lot of centers and what hospitals are doing, where they're wearing the N95 mask, but they're covering it up
Right.
and then changing out the cover of it. However, that's not the best practice. The best practice is to use an N95 as a single-use device.
Right. So let's make this clear. If you're going to use an N95, the best practice is to throw it out after every procedure. However, that's not financially a good option for most organizations, and not to mention you're going to go through N95s very quickly.
Financial is not an excuse.
I know. Well,
Inability
that's
to
the
get
point.
it is an
Right.
excuse.
So if you are going to use an N95 in the procedure room, the better option is to wear it and then cover it completely. It has to be covered completely by a procedural or surgical mask.
and
And,
the other
and
thing
Lori
too
and
is
I will, I think,
do a head, also the face shield as well over that, because
Thank
then
you.
that would help for any splash coming up. But
and,
it's
and one of the things to point out is you're not required to wear an N95 mask in the operating
Thank
room.
you.
That's something that your center has to make the choice
Mhm.
of when you're going to use N95s.
Right.
Lori and I have been debating this all day.
I'm
Doesn't she look
surprised
like
you do
I
it
beat
for
her up?
self-defense. They play devil's advocate to each other.
Yeah, I'm the bad guy.
Trying to give some guidance, and Lori ruins it every time. So
What can I say?
Well, and I guess that's the point that I want to make here is that our viewpoint here is very well thought out, and I can guarantee you, knowing the two of them, that they have considered every angle here. So when we make these comments, we take them pretty seriously, and I think they are indeed the best guidance we can give.
So Lori, should we talk about all the things that they should take into account when they're deciding about whether or not they need an N95 mask?
Oh, sure, go
Very
ahead.
quickly. 'Cause
I'm
we're already an
exhausted.
hour.
Think about it. What all the big guys are saying to you is the CDC, the FDA, the American College of
ASA.
Surgeon, AORN, Respirators of America, all those places. If you're doing high risk cases of like head and neck, so they say above the clavicle, so anything above your shoulders, If you're doing intubation or extubation, and even if and endoscopy, I mean, it's above your shoulders, you know, an upper case, they recommend that you should use an N95. How, you know, so you're
when it is a suspected or known case of COVID. But depending on where you read, like some people consider everyone a suspected case unless you know. Even with testing, some, like we were reading today, the American College of Surgeons has a little graphic that we were trying to, or one of the articles from the American College of Surgeons had a little graphic on, you know, if you're testing negative, positive, and if you're screening negative, positive, or no, I think you screen first and then you test negative, positive. And if they're negative, they said, you know, you can use your normal PPE that you normally use during surgery. However, in a little box on the side that said, anytime you're intubating, you should be wearing an N95.
Right.
So we're getting mixed guidance. Some centers I know that are up and running with the COVID-19 testing are still choosing to wear N95s. And I think that's not necessarily a bad thing. But I think you're going to, you know, I think it's probably the best practice if it's available to you, you know, just to be the safest. However, if you're testing everyone and you're ramping back up to full capacity, I don't know if realistically you're going to have enough N95 masks to be able to do that if everyone's testing negative. So that's going to be a choice that your center has to make.
Right. And so, you know, you have to figure out what the risks are that you're taking. Just like you're going to make that list of what cases you're going to be accepting, what your patient criteria is going to be. It's all going to be, they're all together. They're all intertwined. And then if you decide, yeah, we're going to wear them for all upper head cases or intubation, extubation cases, well, then, you know, then you're going to follow those guidelines. And those guidelines are also going to include, you know, keeping people away from the, you know, the field during the intubation and all that good stuff. And, you know, you're going to look at your airflow and blah, blah, blah. So, I mean, this is not just a yes or no question or answer. But if you are doing a lot of MAC cases that are from the shoulders down, or, you know, take into account, you know, I guess when you're able to do cataracts again, I mean, if what's being said that, you know, ophthalmologists are the third highest for being infected, which does blow my mind since most of them aren't even working right now, you know, even in their offices, because it's, you know, non-essential, depending on where you live. Obviously, you know, us in the more city areas, our hands are tied a lot harder than, you know, lovely Christina out in, you know, Boondock Central.
She's not on anymore, by the way, so.
Oh, phew, thank God.
Not doing good.
You know, so, you know, depending on where you're listening from, it's different. But, you know, so then do they have to wear them, even though those patients are not, you're getting almost no sedation at all? So now you really got to think about these things, and you have to get your physicians involved in making those, you know, yes and no's, and then impact you. If you're bringing out an ENT patient that's coughing, doesn't that nurse deserve an N95 just like the one that, you know, the person that intubated them, because they're getting coughed on in the recovery area? So, you know, you're going to have to really do a little soul searching and a lot of consideration on the type of cases and then the type of protection that you provide.
And what I would recommend is whatever decision you make, have your source, your references. So if you're going to go off of the American College of Surgeon recommendations, or it might be a combination, it's probably going to be a combination of, you know, AORN, American College of Surgeons, your own, like I know GI, ASGE and some of the other GI societies have their own specific guidance to GI cases that, you know, you might want to set for GI centers, they might want to cite. whatever it is that you're deciding as far as your protocol is for PPE, have your citations ready so that if there's a question of it later, you can defend it, because there is no clear guidance, right? There's no clear requirement, let's put it.
And Jana, we have a question that is kind of in those lines. Do you know of a risk assessment that you would recommend?
We haven't really been doing what Lori and I have been saying is you put like your, how did we say
Talking
it?
about a formal document so much as,
No, yeah, there's no real.
We had
formal
like considerations and then decision and rationale, I think is kind of what we had separated. So you'll put your like
Documenting the
masks.
process.
right?
Yeah,
And include
your
this in your
thought
quality
process.
improvement minutes.
Yeah, exactly. And the other thing too is if you are fortunate enough and you decide you're going to take it to the highest level, then you're going to take it to the highest level. So you really don't have to document why you're doing that, because there is no reason to show that, because you're taking it to the highest level. If
Right.
you're taking it a little bit under, then yeah, have some bones behind your reasoning, so that it's not just, well, this is what we decided, and there's no rationale behind it. If you can come up with a good explanation, just like when the physicians are putting in their notes why they've deemed this an emergent case, or a medically necessary procedure. Same thing with your decision on your PPE or your respirator use. I mean, the PPE up into the respirator should all be the same, and the respirator is its own little world. All the other PPE should be your basic standard, however you want to word it. But that PPE should never have changed. I think we just became very complacent in not using it appropriately.
And again, I want to welcome everybody to the ASC N95 podcast with John Goehle. So just kidding.
Can we make this is the last time we'll have the N95
Conversation. Oh.
conversation, or else Jenna and Lori are going to stop showing up.
Right.
I did want to go back. Did we talk about SPDs during the in-service section? SPD, making sure that your SPD people are fully brought up to speed. I see Judy kind of waving her head there. You want to chime in? Somebody chime in.
And whether, even if they get very busy, whether they're going to need more equipment to avoid immediate use,
Yep.
All that kind of thing.
Yeah, we've talked about that. That'll be talked about on Wednesday as well. But yeah, they're you have to think about them. Just because we don't see them doesn't mean they're not there.
Yeah, and be sure to get those competencies, especially if they were furloughed or laid off and they haven't been using the equipment in 6 weeks.
Mm-hmm.
Put them through the specific competencies for those machines, for that equipment, to make sure that they feel comfortable.
Judy,
because
you bring up, yeah.
I think they will be a little overwhelmed right in the beginning.
Yeah, I want to emphasize again what Judy just said there, that if you're off for 6 to 8 weeks, your skill set is going to be down a little bit. So I would say it's pretty much required that you redo your competencies for everybody in SPD.
And if you furloughed your nursing staff, you have to, even your glucose meter, all of everything they would have used in those 6 weeks. Not everything is exactly like riding a bike, just to get them. And I think there are people, when they do come in to check how we responded to this craziness, people are going to ask those questions.
Yeah.
And the more you get done and the more you document, the better off you're going to be.
And then I'm going to segue into something for you, John. Speaking of furloughed staff, so let's say that on Wednesday, people tune in for the infection control training, blah, blah, blah. Are they able to forward that information to their furloughed staff so they can look at it before they come? Or is that anti-furlough rule?
It is anti-furlough rule. If you require them to go through training before they come back, that training that it might be done at home would be compensated time. So, you have to pay them for the hours if they're hourly, and you have to pay them for the day if they're daily. I don't follow you better check with a lawyer if you're not going to pay them.
They're salaried is the word you were looking
Salary,
for.
thank you. Yeah.
But can they get a link and then like a couple days? I'm wondering though, getting a link and then a couple days before they come on, start.
Yeah, as
some
long
of
as they're
the
paid,
stuff.
even if it's at home. I know
Yeah.
a lot of employers are very reluctant to pay people when they're working from home. And there is a reason for that too, because you you know, if somebody gets injured in their home while they're while they're watching, you know, they crane their neck while they're watching
Yeah.
our training. Technically, that is a workers' compensation claim.
But bring
So,
people in a couple days early
Yeah,
because you've
I
got to get
agree.
them familiar with, start cleaning stuff up, start doing these in services.
And some of my centers are doing a combination of bringing, especially the centers that are open for urgent cases have been doing a combination of, some days employees are working at home and doing online trainings or meetings or whatnot. And then some days they're coming into the center and doing cases. So that might be an option too, if you're doing kind of a slow start as you bring people on. Obviously you're gonna need to do, they're gonna have to come in a couple days before you actually start surgery to get everything set up to go.
Okay. Let's just kind of quickly talk about some of the challenges that some of our centers are having as they're reopening. Judy, I just want to kind of have you mention a little bit the mandatory education stuff. Kind of reminding people that that's coming up. Good idea to kind of get it done before too long.
Especially if you have people that you want to bring back and you have things that they need to do, this is a fabulous time to do mandatory education. Even if you weren't actually to your year yet, it hasn't actually been the annual time, it doesn't matter. Because again, these people have been out of your building for 6 weeks. So the more education we get them and the more time we can use them. So especially if you're a client of ours and you have the access to the one that we recorded last week, even better. But there isn't going to be any leniency in the things that need to be done annually. Those OSHA trainings and the PPE training and the things that you have to do every year, you're still going to have to do every year. So you have the time now, and you have a cool resources from us. If you want to do it from a video point of view, we have that ready for you. So this is a perfect time, absolutely perfect time.
So that what Judy's referring to is we did record a live mandatory education training. I believe it was a little more like 4.5 hours, I think.
A little more.
Yeah.
Probably didn't talk too much.
And it is the portion of the mandatory education that is, what do we call it? Common Core. In other words, all centers would have this type of training. You're still going to have to supplement this with your individual training on individual policies and procedures and programs. But this takes care of more than half of a lot of the educational programs that you have. And that's available, again, at our website at ascpodcast.com at a very reasonable price. If you're a client of Amateur Healthcare Strategies, it is free, of course, because it's included in our regular retainer. I did want to kind of briefly bring up, as we are starting to open, there's likely to be in many states like New York and probably Massachusetts and some of the other big states, some requirement for testing. And that there's a lot of questions that are asked of us about wave testing and whether those tests can be done in the surgery center. Now, the answer to that is there are a number of those tests that have been approved for wave testing. In other words, they can be done in your center under the...
No, 4.
Okay, 4 of them, not many. Did I say
I don't
many?
know if that's many.
Yeah, you're right. So there are 4 tests that are approved. Now, Jen, you might want to mention that some of those, you might be able to do them, but you probably wouldn't have the equipment.
Yeah, so 3 of them require a special device to run the specimens that an ASC won't get. And I know for the one test that one of my nurse managers tried to get, she was told by the supplier that they're not allowed to sell it to anyone but hospitals and maybe urgent cares, right now at least. And then that same test ended up being the one that FDA came back, I think this past week, and said it's under investigation because of inaccuracy issues. So might have been a good thing that she couldn't get it.
Yeah. That will be an ongoing problem as you open up.
It is still an approved test though. And I don't know, we might end up with half the tests that are on the approval list right now have issues later. We'll see. They're all, they were all emergency use authorization meant they were rapidly, tested and pushed through. As more testing gets done with them, they probably will have a better idea of what the actual accuracy is. So anyways, there's 3 that require the special equipment. There's one that, and those are all molecular tests. If you're in New York State, I know one of the things that we think is going to happen is that when they send out the directive for ASCs, they're going to also require us to do the testing that's required for the hospitals currently. And the hospitals right now are required to do molecular tests. There is an antigen test that just came out, I want to say last week, that's approved for CLIA waived. And I don't know enough about antigen testing. That's kind of a newer thing. And I've heard there are some issues with the accuracy of antigen testing. So it's an approved CLIA waive test. So if you can get it, great. If you're in New York State, it might not be the best option if you're going to be required. We don't know the requirements yet. So it might not work if you have to do a molecular test. And then the rest of the tests are moderate and high complexity tests that need to be done in a certified lab. So we talked about that on our state association meeting today, because there was a lot of confusion about collecting the specimen at the stab versus running the test at the lab. So if you're collecting the specimen and sending it out to a lab, that's fine. And I know some of the centers were talking about setting up tents outside to do some of the testing. But the CLIA waived testing, there's only those 4 options where you can actually get the results in your, collect the specimen and run the test and get the results right in your center. Does that clear things up? Or does it create more confusion?
I think it's about as clear as we can get it right now.
So the other challenge that we were hearing about today are the varying times of getting the results in. I know one of the centers was saying today on the call that they had to cancel a colonoscopy today because they didn't get the test results in time. And I can't imagine that the patient was very happy about.
They had already prepped, right?
Yeah.
Yeah.
Yeah. So, depending on, you want to think about the timing. Obviously, you want it as close to the procedure as possible, but you also don't want your test results to not get there in time. So that's a conversation you're definitely going to want to have with whatever lab you contract with, is how fast you're going to get the test results. I know a couple of my centers, they're doing a test that they're doing the test 3 days ahead of time and they're 48-hour turnaround time. So they get the test results the day before. And the other thing is, in New York State, for the hospitals, they're required to do the test within 72 hours of the procedure. So we don't know, again, that was a hotly discussed topic today on the call because of the issues that people have been having. Is that 72-hour requirement going to also be required for us?
Now, I do want to make a point here also, is that even in situations where, if this, remember the requirement either from a regulatory standpoint to follow regulations or also the community standard. It's going to be interesting, and Laura, you might agree with me or disagree, but community standard is one of those things that develops over time. And if we find that organizations are generally requiring testing, this could become something that will become a community standard that other organizations will be expected to do. Where community standard issues pop up is in lawsuits after the fact. When Lori and I do legal work, often we have to attest to the community standard in a community. And I think that's one of the challenges that we might have, is that those organizations that choose not to do testing, given the amount of organizations that are probably going to be required to do it, might find themselves in a situation that if they're not doing that testing, they're going to have to stand up for that in court if they get sued.
Yeah, they look at what's usual and customary within your area or your patient location. So if 4 out of 5 are doing testing and you're not, and there's an outcome that is looked at legally, they're going to say, well, the other 4 are.
Right.
So whoever's doing the research for that legal case is going to probably be calling all of your friends
Yeah.
to find out what you do there. So that, it's just one of those things. So, keep an open communication as well with other facilities or other providers in your area to see what they are doing.
Okay, gang, we are an hour and 20 minutes into our episode here. We're going to have to cut some of the items that we had on our agenda here. I did want to get to the PPP program because I think that's something, needless to say, we have a lot of more materials, a lot to talk about. Please visit us at the ascpodcast.com website. Please tune in on Wednesday to Lori's program. Please listen to our other quite long. I mean, all of these things are going long. Just there's so much information to impart. The ASC Roadmap to Recovery, for example, that conference, which is available at the acpodcast.com website, gives you a lot of good information on this. But still, things are evolving as we go along. Zach Kaloritis, I have him on the line here with us. Poor Zach has been waiting to talk about the PPP program, and I'll help you out,
No
Zach,
problem.
on this.
Sure thing.
But basically, the PPP program, the Paycheck Protection Program was an SBA program that was made available. And actually, you surprised me today, Zach. I didn't realize that money's still available in this program. So can you talk a little bit about what's been going on, what we've learned so far today, and then I'll follow up.
Sure thing. So the SBA released an FAQs statement for frequently asked questions, which is fairly in-depth as I understand. I heard about that actually through an article in Forbes posted last week, and they went ahead and summarized just some of the main points that the FAQs went into more detail about. So some of the main points that this article pointed out in Forbes were that businesses with a PPP loan that are under $2 million are still eligible for forgiveness without showing proof of financial hardship. So in other words, basically acknowledging that everyone is assumed to be under financial hardship because of COVID-19. There's no longer the requirement to have to prove that in any type of way. There was more clarity given on partnerships and language about seasonal employees going back for more money. In other words, if a partnership is structured, if a business is structured as a partnership, this new guidance had language to include, if the loan did not include any compensation for its partners, then the lender may submit a request to increase the PPP loan amount to include the appropriate partner compensation for the partnerships.
So in other words, if when you initially applied for it, you didn't take into consideration the partner's compensation because of the confusion, at the initial confusion as to who was eligible, you're able to go back and ask for more money here. Good.
Yep.
Okay.
So again, just more guidance about that. And then lastly, they pointed out that there is still, according to this article, there's still $120 billion left in PPP funding. So they're encouraging businesses, if they're still in need, to take advantage of that while it's still available.
Good. And we are still waiting for guidance regarding reporting. In other words, we know there's going to be some reporting requirement. Most likely it will be to the bank. I think what that means is that the government, the SBA, might give guidance to the banks as to how to report, but the banks will ultimately be responsible for that, as well as the audit function for that. What else was I going to say about the SBA? Oh, one of the issues that's been popping up too is that people keep asking this question. I think you know by now that if you don't start using the money after you receive it or shortly after you receive it, you're not going to be eligible for the forgiveness. So in order to be forgiven, you need to use the money for payroll by bringing those individuals that you laid off back to work, or keep them on your payroll for the 8-week period after you receive the funding. The question has come up a number of times, I'm not ready to open, so I don't want to hire my employees. And that's perfectly fine. Just recognize that you won't give you will not get the full forgiveness. That still means that you got a loan. It's a low interest loan. It's payable over a 2-year period. I think the interest rate is 1%. So it's still not a bad deal to get you through this, but recognize you will have to bring you will need to bring your employees back in the 8-week period after you receive the funding in order to be able to get the full forgiveness there. And if you don't bring back all of your employees, you will only get a percentage of that forgiven. Did I forget anything?
Sounds good to me.
I think everybody is exhausted right now. I'm looking at
I have a question,
Sure, go for it.
but not about the PPP. So I just got a copy of the attestation that the Massachusetts ASCs have to fill out before they start doing cases. In that attestation, they are required to have designated a compliance leader at the highest level of the organization who's responsible for overseeing ongoing compliance with the standards and criteria outlined in the Department of Health provider reopening guidance. So that might be something that, you people in other states may not have to do yet, but it'd be something to think about, who you would delegate for that, because at the start of this form, it says that the person who's filling it out, who the individual responsible for compliance is either that authorized compliance lead or the CEO.
Right.
So it's spelled out for them. I don't know if it was like that for the hospitals in New York, but
Was the
that's how it
CEO
is right now.
certifying it, and or the administrator of record. Yeah, again, that certification attestation was very scary in New York. Sounds like yours is very scary too.
Oh yeah, it's under penalties of perjury.
Perjury, exactly.
Yeah.
So again, so let's just bring this all to a close since we are an hour and a half into it, and I appreciate everybody's patience and thank you, staff, for everything. But does anybody else have any last minute thoughts? Other than we
Oh,
all.
sorry, that was loud.
Well, thank you all for the support of our podcast. I do want to kind of lead out with just a comment that we talk a lot about all the stuff that we make available on the ascpodcast.com website, all of the free materials, and of course the virtual conference. We have Ambulatory Healthcare Strategies, though the executive sponsor of the podcast, is very much involved on the day-to-day activities of regulatory compliance in your organizations, and we are here for you all the time. We've actually picked up quite a number of clients during this time frame because people have realized that this is it. That's just too much work to try to maintain the regulatory compliance while actually taking care of patients, which we know is your primary responsibility. So please understand that we're here for you. Please reach out to me at what is our info@ah-strategies.com, or if you can't remember that, just type info@ascpodcast.com. Call me on the phone, 585-594-1167. We'd be glad to answer your questions and help you out, because this is tough. There's never been as difficult a time frame, I think, for regulatory compliance as it is now. So, well, that's it for this episode of the ASC Podcast with John Goehle. Join us again whenever we decide to do this again, probably in a week. And please consider becoming a patron by going to our website at ascpodcast.com and see all the benefits of being a patron. And spread the word about our podcast with your friends and colleagues, and do us the honor of hitting the subscribe button. Sound editor for this episode is Susan Cronkite. Executive producer is John Goehle. Research assistance is provided by Susan Cronkite, Jenna Alvarez, Judy D'Ambrosio, Alex Borneman, Zach Kelritis, and Lori Rodericks. Music is provided by Media Sushi and Mike Noah. The ASC Podcast is with John Goehle is hosted on Podbean and is available on all major podcast channels.
This podcast is an educational and operational tool and is not intended to be a comprehensive resource for all rules, regulations, and standards that an ambulatory surgery center must meet. The advice provided should not be considered as, nor does it constitute legal advice or opinion. When reviewing specific situations involving legal and regulatory issues, attorneys and other professionals should be consulted. This has been a production of Eden Group Development. All rights are reserved. We would like to thank our sponsors, Ambulatory Healthcare Strategies, Surgical Information Systems, Encompass Healthcare Data Solutions, BHG Patient Lending, Medicus IT, and our newest sponsor, Intelare. For For more information about our sponsors, visit our website at ascpodcast.com. If you're interested in advertising or sponsoring the ASC podcast with John Goehle, please email us at info@ascpodcast.com. We would love to hear your questions and comments. Please email us at comments@ascpodcast.com.